Okay, so let's touch upon a topic which I think is important for everybody. You do adult cataract surgery at the age of say 60, 65, 70. If he's lucky, he might touch 100, become a century, if he's lucky. So you got what you investing your energy and things for people who are going to live for next 30, 40 years, right? Here, the kids are with you from say 1 month, 1 year, 10 years. They're going to live 80 years. So please invest wisely in picking up your machines and your surgical skills. And pediatric cataract on the rise. So this is what you see. If you see the epidemiology, so it's counted in 10,000 units. So 1 to 15 in 10,000 live births is what you have these visual impairments, and blindness in this is 1 to 4 in the developed countries, the Western ones. And the developing countries, it's 5-folds more, right? So there's more than 1 million children are blind in Asia because of pediatric cataract, which is totally operable disease. And 200,000 are bilaterally blind because of cataract. Okay, so before I go there, the problem is, whenever the patient comes to you, the first thing the parent asks, the child having a cataract never heard of, because it's supposed to be disease for the senile, old age. So the parents have to be taught about the disease. That's the most important, because the follow-ups, the compliance for occlusion, the glasses usage, and recurrent change of glasses on timely intervals, I think that's the cornerstone for the treatment in these patients if you really want to manage this patient. If the patients don't want to wear glasses later on, you left the patient faking, it's as good as a blind patient. So the parents and the teachers in the school are to be taught and explain that this child should be allowed to sit in the front row in case he's not able to manage, and we try to give them the aids so that they can cover up very well. The unilateral cataracts will need patching majority of the time. When they come to us at the age of 6 months, 1 year, one eye has been good since birth, the other one is not seeing at all, maybe a deviation or sensory deprivation, and they need occlusion. So you have to be very careful what you do, and the parents have to be taught and sensitized about that. So basically, it's more important about teaching the parents about the disease and how they'll manage the child, because they're going to manage, not us. We'll just do the surgery and let the patient go back home. Okay, the parents come with one child and they got a big family. Please call all of the kids, and you'll be surprised at how you pick up. If you keep seeing all the parents, especially the mothers, if the mother is having spots, specks in the eye, or maybe a zonular cataract, it could be a Nance-Horan syndrome, which is coming by the X linked, and the male is involved, the females are not involved. So you can pick up a pattern and follow what is happening in this patient. All the sibling has to be seen, and I see these patients only one promise. I see the child that the parents will sit there for 15 minutes and have a tropicamide drop put in all 4 eyes, 2 for mother and 2 for the father. Give them 15 minutes and do a distant direct, put in the slit lamp. You'll be surprised to see the findings, right? You might pick up mitten dots which are there in the eye, which are not significant, but you get findings. So whatever you look for, you normally get it. So be alert. And it's not a one window. Adult cataract comes to you for surgery, you do a surgery, you do a phaco, you do a sutureless surgery, put a multifocal. He'll pay up front and go back home, will never come back to you till he has a VO or some other surprise injury or not. Here, the problem actually starts after the surgery, because you're not giving the zero power refractive errors, you're giving refractive errors to these patients so they can grow out later on into this power. So that becomes very, very important for us. Second, so resurgeries might be required. If you're handling the unilateral cataract, don't commit yourself that it'll be one surgery. Even for the bilateral, you might have a VO formation despite doing all the techniques which we'll be teaching you right now. So you can never be 100% sure which is the eye in which the excess will stay clear 100%, and there are none. So any of these patients can go into opacification. Okay, so they have to use glasses now forever, at least for life, or till they become adult and their number becomes stable. Then you can do whatever bifocal, this thing on the surface, contact lens, whatever you want to try, but till they become adults, it's your responsibility to follow this patient and keep following them up properly. So as you know, it starts very early. Before even the mother knows that she's expecting, she might have the lens which has started forming in the eye. So lots of time you see it's maybe it's a smoker, or the family is having drinks. So it can cause, but nobody knows about sure why it happens. We're still having lots of congenital cataracts, but this is how it goes. I think we all know about the embryology. If you see the data all across the globe, there's no country which is not having pediatric cataract. United States earlier was having very less, say about 2.03 in 10,000, but now with the migratory population, people coming from Mexico, India, Pakistan, Sri Lanka, they're all going there. Of course, you haven't changed their genetic formation, so if they're prone for cataracts, they'll definitely have one. Even there's a study in Australia, they found 2.2 per 10,000. India, we have about 45. We did the study at the RP center where we belong to. We picked up this patient in which we saw the lenticular abnormalities in the lens clinic. It was a huge data. And we realized that this is what we're getting. We're getting developmental cataracts in about 45% of patients. 30% patients of these were traumatic cataract. We put them in a different category because these are, again, avoidable injuries. In USA, 4th of July, they have fireworks, maybe more than what we use in India, but they are all controlled. I mean, there's a park, people sit at the back, enjoying themselves. In India, everybody can buy on the street, and the kids are playing and throwing it on each other, and that's what we get. And Eric, I mean, that's the problem we have. I mean, we're getting unilateral blinds a lot because of this trauma. And the last number 10 is a visual excess opacification. That means you've done the surgery, somebody's done the surgery, he hasn't taken care of the posterior capsule or a vitrectomy, and still there's opaque media. So it doesn't help anybody. Till the light goes into the retina, it's not going to stimulate the retina. So we need to have a media open. So these are the things which one should know. So with this, Vision 2020 has this, WHO has this in the right, it's the right for the child. So one blind child is equivalent to restoring vision of the 10 adult cataracts. That's what this says. So if you do adult, pediatric versus pediatrics, ease of surgery for pediatric surgeon, I think he's happier doing a pediatric more than the adult ones. And the reverse might not be true. A great successful adult cataract surgeon might not be a good pediatric surgeon because you need to do a posterior excess, which we'll be talking about. Putting the lens techniques are different. So everything is a different ball game altogether. So what this course is going to be talking about, we'll talk about the preoperative evaluation, which Dr. Nayan going to cover up, and then operative tips and tricks, Dr. Diksha, who's from Mumbai, she's going to cover up. And what are the post-operative consideration in these patients, that, and plus the IOL power calculation. So calculating the IOL power in this one is very iffy and tricky, and of course we're going to guide you how to pick up your thing. And the newer images, what about the role of IOCT UBM, and we're going to be covering all this. So with that, I'll ask Nayan to please come on the stage and take his talk. I'll put you onto that, Nayan. That's yours. यार वो दोबारा उसमें जा रहा है, वो उसको सारे को उसी में कर दो एक में यार. I don't want a dual display here.
Good afternoon, everyone. I'll be discussing preoperative evaluation in pediatric cataract eyes. So the first step, as the parents come with the child, they are worried, they're anxious, they want to know the prognosis, they want to know from you whether you can implant an IOL, what will be the rehabilitation course. They are worried. So first thing, you need to calm them down, ask a detailed history from them about their antenatal period, their prenatal period, any drugs, any illnesses, any rashes on the body, and if a patient has a history of trauma after the birth, these all things are important. Detailed history, how the trauma, and if there are any open globe injury, closed globe injury should be evaluated and asked for. Second thing is to assess the visual acuity. This not only helps in giving prognosis to the parents, but it also helps in how to rehabilitate the patient. Then third step would be systemic evaluation. Since most of the bilateral cataract or few of them are associated with systemic association, any illnesses, so we need to evaluate. Fourth is the ocular examination. In pediatrics, you can't make him sit on the slit lamp and examine the eye. So we need to take a different course to examine the eye. And fifth is the biometry, which is done on the table in, under anesthesia. So what are the complaints which with parents come for? They come with a complaint of whitish reflex noted by the grandmother or aunt or the mother herself while feeding the child. Then there might be few children who are rubbing their eyes. This is ocular digital phenomenon. Then few patients, like in this one, the child squeezes the eye on the eye in the same side with cataract. and there is spasm of the face on this side. This child is also photophobic. Few parents notice abnormal ocular movements in the child, and then they report to an ophthalmologist. In this eye, it was difficult for parents to notice, but at the age of 1 year, they noticed that there is difference in the size of the two eyes, and on further evaluation and on in the OR, we found that the child had PFV in the left eye. The causes of the leukocoria can be anterior or within the lens matter or posterior to the lens. Anterior, it can be due to the cornea or anterior segment dysgenesis, and posterior to the lens, it can be retinal detachment, toxocara, persistent fetal vasculature. Now, to assess the prognosis, to give prognosis to the patient, we need to assess the fixation, especially in child with congenital cataract. So it may or may not be central, steady, and maintained. These three things are most important. Central suggests a foveal fixation. Steady means child does not have abnormal wandering movements or nystagmus. And if there is a media opacity for a long duration, child might have developed strabismus, due to which there is, he or she does not maintain the fixation. Visual acuity assessment can be done by the tellers or OKN drum or a Catford drum in pre-verbal children, in toddlers or infants. In 1 to 2 years of age group, we can go for Cardiff, which is based on vanishing optotype. 2 black lines separated by a white band, and which can only be visualized at a particular distance or lesser, and then it gives a better idea of visual acuity. Then ivory marble ball test. Then you have Steiker for retards and young children. Miniature toy test, where on screen the same toy is shown in a bigger size, and the child has to pick up the toy of the smoke. Then coin test, and then you have Lear symbols. In 3 to 5 years of age group, Allen card test, HOTV, these are the first letters which child can identify. In more than 5 years, Snellen's, Landot C, and tumbling E chart. How to examine a child? That's the most important thing, because child is anxious, and there is an inbuilt white coat syndrome because he has received all his vaccinations at this age group. So the best position, if the child has developed neck holding, is the shoulder hold. The child has maximum contact with the mother, and child feels comfortable and shows easily. For those 1 month, few weeks old, it's better to hold the child in mother's lap and then examine. Any abnormal facies, head circumference should be noted at this point, because one might suspect congenital rubella syndrome or any syndromic association. In cases of unilateral cataract, pupillary response become essential, since it might be a RD, it might be a PFV, and prognosis might be grim, which we need to determine before we go into the eye. Distant direct examination and dilated pupil examination are important. This patient came to us with bilateral aphakia. Now, when we dilated the patient, the lens, microspheric lens, came anterior, and it can be seen dangling in the anterior chamber. Now, these children need to be made stable to undergo the surgery. So, systemic evaluation, if any history of seizures, then neurological consultations, and anti-seizure medications. In cases of uveitic cataract, which we are receiving these days in a large number, one must start biologicals or methotrexate or MMCs. Then for the galactosemic patients, one has to go for urine and blood sugars. These are few syndromes which we have picked up at our center. Alagille syndrome, broad nasal bridge with epicanthus palpebralis, moderate hypertelorism, butterfly-shaped vertebra, lamellar cataract, Larson syndrome, which is inbuilt deficiency of collagen 7 synthesis, has patchy alopecia, syndactyly, polydactyly. Then this one with fetal valproate syndrome has anteverted nares, broad forehead, telecanthus, flat upper lip and thick lower lip, and inguinal hernias. Sickle syndrome, X-linked hypophosphatemic rickets, and trichothyroid dystrophy recently picked up with a tiger trail appearance of a hair shaft on polar trichoscopy. Now, to examine the child on the table, the first step is to do the eggshell length and the corneal diameters, because it allows us whether to determine whether we are going to put an implant or not. So if we take a cutoff, if corneal diameters are less than 9 and eggshell length less than 17, then we might not put an implant. But in eyes, in unilateral cataract, we might go at borderline values. Second is the keratometry assessment. Handheld keratometers can be easily used to assess the keratometry. IOP assessment becomes essential in uveitic cataract as well as rubella-induced cataract, micro-ophthalmic eyes, to rule out glaucoma at this point. Angle assessment becomes essential in cases of blunt trauma where there might be a chance of cyclodialysis, iridodialysis, which is missed on pre-op evaluation, which can be easily assessed by Swan-Jacob gonioscopic lens. UBM is must, and it helps a lot in most of our cases, especially in cases with posterior capsular defect with persistent fetal vasculature. These cases can be easily picked up, and the surgeon can make up his mind how to approach the case before even going into the eye. These are few photos which we have picked over time. Ultrasound biomicroscopy will be discussed by Dr. Amar in next. IOL estimation has to be will be discussed by Professor Coker. Thank you. Now,
Thank you. So I think before you actually decide to operate, you have to know where are you standing. I mean, if there's a cataract, doesn't mean that you see an opacity, you jump in to operate, right? And if there's a minimum cataract and there's abnormal eye movements, there's a deviation in the eye, of course you have to go and operate these patients. So anytime you have a sensory deprivation or a strabismus, these are the ones in which you go right ahead. So you have to decide, a cataract with a straight eye, the patient having 6/12 vision on refraction, you can always start glasses. So when you glasses here, the advantage is that after surgery also they have to wear glasses. So parents actually get sensitized for the child to wear glasses. So after cataract surgery, if you're living a phakia with the power of say +18, they will not be able to handle glasses that time. So if you're putting the pre-operative, even if the vision loss again is not too much, you are actually playing the psyche of the parents that this child has to wear glasses for his life. Okay, so thank you for that one. And there are certain things which you might have not covered, so I think we'll obviously ask, we can discuss at the end about that. I think we got Eric and everybody who can pitch in. So once you decided which one to operate and how to operate, so I think I'll ask Diksha to come here and tell us which ones to go and how do you want to go about the surgery. Diksha. Can you give me a mic here?
Good afternoon, everyone. Thank you, sir, for this opportunity. So I'll be discussing, excuse me. Okay. So I'll be discussing surgical management of pediatric cataract. Karu? It's still cutting. Okay. All right. So first is the factors determining the surgical success. The meticulous surgery, of course, is important, along with a proper follow-up and a compliance to glasses and occlusion. And good anesthesia team is mandatory for all this to happen. So basically, we're just understanding the basic concept. Why do we want to operate a pediatric cataract? So the idea is to clear the visual axis. The central optical area has to be clear. You have to remove the scaffold for PCO formation, which we know is the most common complication of cataract surgery if not handled well. And we have to maintain the support for IOL because the child cannot be left aphakic with high glasses power to wear on. The surgery should be least traumatic and we should target to have minimum complications. So next is which one to operate. So cataracts which are very early or lamellar, we might go ahead and just observe those because while operating, accommodation is a very important factor which we deprive the child of. So the indications of surgery would be central cataract larger than 3 millimeter, a posterior cataract which is closer to nodular point and which causes more hampering in the vision, patient having nystagmus or strabismus, and if nystagmus is present, it is less likely that the vision would be really good, usually less than 6/12. Next is when to operate. So ideally as early as possible, but there are certain other factors to consider in terms of intraoperative complications like glaucoma, which are higher for children operated at a younger age, and the risks associated with anesthesia, which are again higher for younger children. So the usual consensus is about 4 to 6 weeks for unilateral cataract, because in these cases the risk of amblyopia is higher, and for bilateral cataracts it is 6 to 8 weeks. In symmetrical cataract, second eye is usually done within 1 week of the first eye, and if the patient is systemically unstable and GA is risky, we might go ahead and operate both the eyes in the same setting. So why does pediatric cataract surgery need more care? Because there are certain challenges in the eye itself. The anterior chamber has higher degree of instability. The capsule is highly elastic, more difficult to manage. Scleral rigidity is low. Again, the chamber may fluctuate. There's a tendency of visual axis opacification, so we need to do certain extra steps to prevent that. Whereas the nucleus is very soft and it is very easy to aspirate. So starting the steps one by one, the very first is the head positioning, because if the head is not centered well, you'll keep struggling the whole duration of the surgery and the outcomes might be suboptimal. So ensure a proper exposure of the eye. So the children need a proper, a proper ring size. So here is the video showing the appropriate ring size. So after the child has been induced, the head and neck is elevated and the ring is placed under the head. This ensures the stability of the head and a proper exposure. And for younger children and even for this age, we need a shoulder roll to ensure that the eye is well centered. So the shoulder roll can be easily slid under the shoulders, again to ensure that the eye is now horizontal and we have a good exposure. We have to choose an appropriate speculum size, because a too small a speculum would slip and too larger a speculum might cause some traumatic injury at the canthus or may lead to pooling of clear fluid in the cul-de-sac. Next we come to incisions. So usually 3 incisions. Prefer making first incision with the non-dominant hand and the second incision goes 180 degrees apart. If the chamber gets shallow, refill with OVD and then make the incision. Do not handle a shallow, do not make an incision in a soft eye with shallow AC. So next is staining of anterior capsule. So here the the trypan blue serves a dual purpose. It not only stains, but it also increases, makes the capsule little brittle, which helps to make the capsular exes a little easy. And then the stain should be well washed out from all the incisions. So next is anterior continuous curvilinear capsular exes, which is the most important and one of the most challenging parts of the surgery, because the pediatric capsule is more elastic and it requires more force to be opened. So usually because of high intraocular pressure, the high vitreous thrust, the anterior capsule of children is like this dome. Whereas if we try to operate here, the rexis is very likely to extend to the periphery. So we need to flatten the dome by injecting heavy viscoelastics. So after injecting heavy viscoelastics, once the dome is flattened, we have a better control over the capsule. And we also need to ensure the adequate size of the rexis, which can be done with markings on the cornea or the intraoperative guides. But sometimes, like most of the cataracts are zonular cataracts, and we have seen in our experience that the size of this zonule is usually around 4 to 5 millimeter. So this size of the zonule also sometimes act as a guide for the size of the capsular rexis. However, in certain other morphologies of cataract, vitrectomy can be used to create capsulotomy, and in cases with PFC which have highly vascularized capsules, we may sometimes need to use diathermy or cautery to make an opening. So next we come to hydro procedures. So in pediatric cataract, we need to do a multi-quadrant hydro and ensuring that the viscoelastic is still in the eye. Again, because the vitreous pressure is high, if you remove the viscoelastic, your hydro might be incomplete. So we need the viscoelastic in the anterior chamber so that the fluid wave goes and dissects and creates clear plane. This is then followed by bimanual aspiration of the cortex. Next important step is posterior capsulorhexis. So in this, we need to fill in the OVD in the anterior chamber and not the back. We have to ensure that the capsule does not get pushed too much down. So maintain a horizontal level of capsule, and then very gently we can make around 3 to 4 millimeters of PCCC. Using a forceps is always a good idea. We can make a small nick with the cystotome and then gently complete the circular opening with the forceps. So this step is different, hence it looks challenging, but practically this is easier than anterior capsulorhexis. So certain age limit criteria for PCCC. So PCCC as well as anterior vitrectomy is mandatory at age 5 to 6 years, whereas PCCC alone is usually enough till 8 years. However, if there are any other challenges in the child in terms of certain developmental abnormalities, or there are certain situations like the child might not be able to follow up, in those conditions, in those situations, it is better to do PCCC and anterior vitrectomy for all the ages. So again, anterior vitrectomy with 23 or 25 gauge vitrector, we need to have a high cut rate and low aspiration flow rate. You need to cut 360 degree, and the end point of the anterior vitrectomy should be that the margins of posterior capsule, they curl and fall down. This will ensure that the plane is entirely clear of vitreous. So next important step is IOL insertion. So after the anterior vitrectomy, we need to inject viscoelastic inside the donut between anterior capsule and the posterior capsule. Now the IOL has to go inside this donut. So we need to inject the IOL in such a way that assume as if there is no posterior capsule and the IOL is just going under the anterior capsule. And this is a good means to understand it, as sir usually tells. It's like a landing of the plane. If the plane is landing with the nose down, the IOL will go directly into the vitreous because there is no support. So the IOL has to land horizontally, going down under the capsule, and then horizontally, so that it just fits just under the capsule. And then the trailing haptic can be eased in. So next is the suturing of incision with a suture. This is mandatory for children because the anterior chamber can be unstable. However, for elder children, if the chamber is maintaining, we can skip the sutures also. But for younger children, especially toddlers, it is better to suture. And then the viscoelastic is aspirated and the side ports are hydrated. And the surgery usually ends with a subconjunctival injection of gentamicin, dexamethasone, and atropine for cycloplegia as well as anti-inflammatory activity, because the eye will be patched for a good number of hours. So the day 1 post-op refraction is very important, and details will be discussed by Dr. Venkatesh in the next class, in the next talk. And so post-operatively, we prescribe prednisone, homide, and antibiotics. So this is what this was a general overview of a normal pediatric cataract. The technique needs to vary in certain variants, which we're not covering in this IC now. So thank you, sir.
Oh, thank you, Dr. Diksha. So we put in across a simple cataract which anybody can operate. I mean, if you have any queries, you can see the videos. It's not a difficult ball game, provided you get at it. And as we said, the patient's number is increasing, so I think it's better that you people actually buckle up, be prepared for that. So once you've done the surgery, and we talk about the simple cataract, we're not putting any PFBs, complicated PCDs and all those, but I don't think this is the forum for that. We can have the discussion later. So once you've done that, what are the post-operative regimes, and what do you do for the patient which are aphakic, which come to you surgery done outside? How do you manage the secondary? I think that's what Dr. Venkatesh, who's a practicing surgeon in Rajasthan, Bhilwara, is going to talk about. And these are all trained at the RP center, so you guys are all welcome to come to the center, and anytime you have time, you can come and visit us and learn what we do there. Venki.
Thank you, sir, for the kind introduction. And thank you, Dr. Diksha, Dr. Nayan, for discussing the initial part. Post-lunch sessions, especially pediatric cataract, can be really drowsy for a lot of individuals. but I'll try to make it as interesting as possible. Post-operative care and rehabilitation of pediatric cataract patients. So just after the surgery, post-operative medications are given, topical steroids, pred-acetate, which is usually tapered weekly. So we usually give that for a period of 6 weeks. Cycloplegics, for children less than 5 years of age, we usually prefer eye ointment atropine. And for children more than 5 years of age, we are using home atropine, which is given QID for a couple of months. And topical antibiotics are usually given for a month. Now, from where a pediatric cataract differs from an adult cataract is basically post-op. Post-op is the key for managing a pediatric cataract patient. We have to schedule the follow-up in such a way that we see the patient on post-op day 1, do a good distant direct ophthalmoscopy, measure the retinoscopy, and prescribe glasses as soon as possible. Our colleagues from the West may differ with us, and they may want to prefer no IOL or just contact lenses. In Indian subcontinent, because of socioeconomic strata, not all patients would be very compliant for the follow-up. So it's not a bad idea to implant IOLs in whichever case which is possible for us, which I'll be discussing with you. We thereafter see the patient on 1 week and 1 month. Thereafter, we have a 2 to 3 monthly follow-up for the initial 6 months, then 4 to 6 monthly follow-up for the next 3 years. Infant aphakia treatment study talked about the follow-ups at day 1, 1 week, 1 month, 3 months, and every 3 months. The key of preoperative counseling to these parents of pediatric cataract is the child would need a constant regular follow-up to look for VAOs, to look for change in the refractive error, to give the glasses, change in the prescription of glasses or contact lenses on a sequential basis, and also to look for any complication developing because of the surgery, which we try to minimize with our good preoperative planning. On post-operative day 1, we do a distant direct ophthalmoscopy, observe the glow. We look at the status of the anterior chamber with torchlight or slit lamp if the child is cooperative. We do a refraction testing using a handheld, either using a handheld refraction bars, or we can use separate prescription glasses for the same, and we immediately prescribe glasses at our setup. In unilateral cataracts, you have to jolt the system. When the kid is small, it is like a wet clay. There's a lot of neuroplasticity, so you want to cash in on that neuroplasticity, and you want to patch the good eye so that you jolt the visual system of the now operated eye. Post-operative 1 week, we again look for the glow. We confirm the compliance of glasses and patching with the parents. We taper the medications as has been discussed previously, and we check for the improvement in fixation. We check for visual acuity on Cardiff or Teller's visual acuity cards for young children. Post-operatively at 4 to 6 weeks of age, we do examination under anesthesia where we do suture removal. Most of the times we are doing superior surgeries. So when we are closing the wound superiorly, we are inducing with the rule astigmatism. So you want to remove that induced cylinder by removing the sutures, assess for any visual axis opacification, do the biometry to cross-check your retinoscopy, intraocular pressures, and fundus evaluation. At every possible visit, at least for 6 months, look for biometry and refraction. And if there is a poor red reflex, we take up the kid for examination under anesthesia. And if there is significant visual axis opacification or VAO, we do a media clearing membranectomy. If it is anterior to the IOL, we can go via the anterior route. If it is posterior to the IOL, we make a pars plana port, single pars plana mode, and clear the proliferative VAO from the posterior surface of the IOL. And if there is a gross unexpected refractive error, which is too off from our prediction, then we can go for an IOL exchange as well. Visual rehabilitation, either with glasses or contact lenses, is quite important for the refractive correction. And the second most important part is amblyopia management, which is given via occlusion therapy and active vision therapy. Glasses, we have to make sure the parents are counseled about the importance of compliance with glasses, as we are undercorrecting these kids. We are shooting up for pars which we want the child, we are trying to attain for pars which the child will have when the eye grows. So it is important to give the adequate refractive rehabilitation. If the glass is unequal or heavy on one side, as I can show you in this image, the glass is too big for this child. So in such a scenario, we have to counsel them that use appropriately sized glasses and do not and use high index glasses, so that the thickness of the glass, especially when you're under correcting and you're giving a prescription of +8 or a +10 or a +12, you need a high refractive index glass so that it is thin and comfortable for the child to wear, so that the lashes do not hit the glass. Additional supports can be used, as you can see in these images: cable tampons, goggle converters, or overnet harness for kids who are quite active, who just want to throw the glasses off. But you will be surprised to know, in our clinics, when we are following up these kids, they are actually, when they're able to see good, they are quite compliant with these glasses. The only important thing is the adequate sizing, proper refractive index, and the comfort of the kid with the proper size fitted frame. Aphakic glasses can also be a difficulty, so we have to use a small frame. We should ensure that the line of vision should rest close to the center of the lens, and the frame should have adequate sufficient depth to accommodate for the thick lens, and spring hinges can be used to absorb any impact and to snugly fit the glass. Contact lenses can be used, as has been described in IATS, silicone elastomer lenses, rigid gas permeable lenses, hydrogel lenses. But in this part of the world, in the third world countries as well, the socioeconomic status might not allow the parents, the hygiene might not allow the parents. We have also tried this, but we have burnt our fingers, where the kids actually ended up back to us with infections, keratitis. So it's not a bad idea to put the IOL, if the biometry allows, and then give proper contact lenses. Yes, contact lenses have been tried in educated parents who are able to maintain hygiene and change the contact lens frequently. For amblyopia management, you have to jolt the visual system. There is pre-op deprivation and there is post-op anisometropia. Both of these have to be dealt with amblyopia therapy. The aim is to provide a clear retinal image with proper refractive correction and then correct the ocular dominance by patching the good eye. You can give a corollary of a twin-twin transfusion syndrome, where the good twin takes up all the nutrition from the other twin. So it's a similar scenario where the other eye did not get adequate support from the visual system, adequate supply of the vision. So we have to jolt the system by patching the good eye, so that during this age of neuroplasticity, the child can improve on the lines on the visual acuity chart. The amount of patching is dependent on the age when the retinal image is clear. Occlusion therapy can be partial or total, full-time or part-time, converse or inverse. The occlusion goals are differential diagnosis, improvement of amblyopia, elimination of suppression, awareness or elimination of diplopia, and disruption of anomalous correspondence. The full-time occlusion can be used initially to jolt the system. Age-appropriate guidelines can be used for age 1, 2, 3, 4, 5. It can be 1:1, 2:1, 3:1, 4:1, where the other one is to prevent the occlusion amblyopia. For more than 6 years of age, full-time occlusion can be tried as 6:1. It is better in preschool children. The risk of occlusion amblyopia is always there. That's why there's a need for constant follow-up and counseling of the parents, and faster recovery with shorter duration of time for full-time occlusion. Now gradually you can taper it to part-time occlusion, and this gradual shift from full-time to part-time would actually also aid in the binocular perception of the visual system of that child. There's always a risk of occlusion amblyopia, so you have to check the visual acuity of the better eye, if it's dropping or not, and counsel the parents accordingly. If there is an occlusion failure, the definition is that there is no improvement in best corrected visual acuity in the amblyopic eye on 3 bi-monthly follow-ups. The factors which are common for occlusion failure are poor compliance, age more than 6 years of age, where neuroplasticity wanes off, visual acuity in the amblyogenic eye less than or equal to 20/200, or astigmatism of more than 1.5 diopters. Active vision therapy can also be tried in the form of near vision tasks and fast pointing activities. Certain video games have also been introduced recently as a form of next generation technology, and the possible role of re-education of the amblyopic pathway by intense sensory and motor interactions is known to stimulate the visual processing and enhance the plasticity of the visual cortex. So, active vision therapy can be tried as a monocular treatment, where you can use perceptual learning or monocular video game, or dichoptic treatment like dichoptic perceptual learning and dichoptic video game play. Now, what about certain complications as I talked to you about? Visual axis opacification, or if during the initial time of surgery, the biometry didn't allow us to put an intraocular lens. The indications for aphakia at our center is small eyes where the white to white is less than 9 mm and the axial length is smaller than 17 mm. We tend not to prefer to put an IOL. When the eye grows, we plan for a secondary IOL. We do a EUA for biometry sequentially on the EUA follow-up and the UBM for sulcus assessment. The ideal scenario would be an IOL in the sulcus in such patients. Now, what are the prerequisites for a secondary IOL? I would say 3. Sight, the best corrected visual acuity. Second, specular count, which the very small kids may not allow, but the corneal clarity would give you a clue about the specular status of that eye. And thirdly, most important, the sulcus support. The sight should be significant enough and there should be significant improvement with the intervention, which we can check with the refractive rehabilitation which we are giving. Sulcus can be assessed with the help of ultrasound biomicroscopy to look for the rim of sulcus. We are frequently using 35 megahertz probe, and the anterior chamber assessment during EUA for any peripheral anterior synechia, shallow anterior chamber or posterior synechia. Now here's a video courtesy to Professor Sudarshan Khokar, where in an aphakic eye we are implanting a secondary IOL. You can see we are releasing the posterior synechia initially with the help of a Helon or OVD cannula, enlarging the incision, putting some OVD to create a space, and then injecting the IOL slowly with the leading haptic going in the sulcus and then gently turning the lens, because there's always a torque with 3-piece lenses. So you have to be mindful of the trailing haptic and just tuck it away so that it is centered well, and put the other trailing haptic also in the sulcus. In this scenario, for additional stability, we are doing an optic capture. So once the optic goes behind the fibrotic capsule, it is very stable. What about the scenarios when there is no sulcus? Well, there are some options like anterior chamber IOL, iris claw lenses or iris clip lenses, or scleral fixated IOLs. Well, for AC IOLs, the indications could be no PC support, scleral weakness or irregular iris support like in Marfan syndrome or Beal syndrome, no peripheral anterior synechia or deep AC, and corneal diameters between 10 to 12.5 mm to reduce the chances of corneal decompensation. Adequate sizing, just like an ICL I would say, is very important for ACIOL as well to prevent corneal decompensation. And these are small kids. They have 80 to 90 years to live. So you have to be very accurate with the sizing, and PI is mandatory in these cases. What about iris claw lenses? Well, they are a very good option. Here's a video, the second one, where we are putting a 2-clip lens. You fill the space with OVD, the anterior chamber, hold the lens, gently clip both the claws. This is a retrofixated IOL. You have to just ensure there is adequate vitrectomy which has been done before the implantation of this. Otherwise, you may end up with GRTs if you're not careful with your vitrectomies. Now, what we have recently started at our center are 4-claw IOLs, especially with the smaller eyes. So what about those cases? Less than 9 mm eyes? Well, in these cases, we are using 4-clip lenses which are relatively smaller, though they require a certain amount of surgical dexterity. We have dexterous mentors with us. Here you have to enclave all the 4 claws, first claw being enclaved, then the other one at 3 o'clock. Now these lenses are smaller, so they provide us an additional advantage of implanting lenses in the smaller eyes. It has a significant surgical curve, but once you master it, you can give visual rehabilitation to those cases as well, in which we were leaving patients aphakic. The last claw is the most challenging one, but you can use an additional instrument. In this case, we are using a Grieshaber serrated forceps for additional support and using, just tucking up the 4th lens. So 4 claw sits very beautifully, though there can be some limitations, like the pupil may not dilate as much as with a 2-clip lens. The other limitation can be explantation of these IOLs or IOL exchanges later may be a little difficult, but yes, you can provide this as an option to also patients which we were leaving aphakic earlier. Scleral fixated IOLs in kids, yes, people are discussing about putting SF IOLs, but with elastic and thin scleras, SF IOLs can be an issue. There can be haptic extrusion, there can be melting of the tissue, so you have to avoid scleral fixated IOLs, especially in kids less than 6 years of age. So to sum up, the prognosis and counseling is very important. Tartela et al. Proved that visual acuity improved after surgery in 83% of the eyes, and our experience is also that improvement in central steady maintained fixation in approximately more than 80% of the patients, which was also demonstrated by Khurana et al. And the key to pediatric cataracts is regular and long-term follow-up, pre-operative counseling with the parents, and making them a part of our team. Thank you so much. I had a nice time. Over to you, Professor.
So any queries till now? Anybody, any questions? Or is it clear? So please go ahead. Can you come to the mic? I'll be discussing about the IOLs. How do you calculate the power of the lenses? I think that's very important. And these kids have actually become very good surgeons, so I thought let them talk about the surgery, and they're all doing excellent work. When she says that PC is easier, and she means it, and I vouch for it, because posterior capsule rexus is the easiest thing on the earth you can do. Anterior rexus is not. Sorry, please question.
So at what age are you planning secondary IOL in children?
Okay, so ideally speaking, when the growth stops, right? So ideal is about it should be about 2 years, between 2.5 to 3, 4 years you can do it. But if it's a unilateral cataract, the aphakia, I might go as soon as maybe 6 months, because if the patient not using contact lenses, aphakic glasses is not using. So as he said rightly, our tolerance for the IOL is very low. We put IOLs and we try to fix it. Even the 4 claws we started using, because these are the eyes which are 8 millimeter across, unilateral. What do you do with these ones? And especially there's a group called nanophthalmic eyes, which are normal, healthy, smaller eyes. So none of the lenses will go into those eyes. So these 4 claws, I'll be working on that, and maybe when we come next time, we'll cover the better data. So I think after 2 years, you can actually put. The problem now is that all the parents in which the kids are bilateral fake, using glasses, vision 6/6, they all go to school and they want to come back and remove the glasses. So basically, the peer pressure is much more now than it was earlier, and everybody is so conscious about the cosmesis, the glasses. So we also started doing these lenses quicker. So this iris claw, posterior iris clips, you can do any time, and that's not an issue. The AC lens is a problem because we don't find the sizes now, and the AC lenses are actually come in 2 sizes only, and even those are not available. In fact, in India also, we're not available. They're available, but they were very good lenses, multiplex, but only for the eyes which were 10 years and above, in which the growth is not going to happen. Right? Thank you. Okay. Any other question? 4 claw, I think, is Kiranjit here. There's a company which I think Kiranjit, Daljit's son, he's the one. He sends us. He's supplying us the lenses. So I think I'll ask him to send you the details of that one. Right? There are 2-3 other companies who are making it, but the one which is best is supplied from Amritsar to us. So we'll talk about those ones. Okay. So now.
Sir, excuse me.
Sorry, I didn't
how
see you.
anterior vitrectomy can we perform?
Sorry?
Anterior vitrectomy how can be performed?
Okay. I think that's a very good question. When you've done a posterior rexus, you have to do anterior vitrectomy in all these patients. If you don't do, the scaffold, the cells which are growing from the anterior capsule will go posterior behind the lens and come onto the vitreous and make everything opaque. So the cutter rate has to be maximum. I use Centurion, it gives me 4,000 cuts, which is good enough for me. So I think the pediatric cataract surgeon is almost half a retinal surgeon, right? So you actually have to do a very high cut rates in these ones. And once you've done the central core, go about 3 millimeters into the depth, and then you put a probe upside down under the rexus margin, all 360 degrees, changing your hands, and take out all the support from the posterior capsule. It should fall back. Okay, so that's the end point when it curls back and falls back. And if you created a rexus which is round posterior, and now you find it's oval, that means some vitreous is still coming in. And if you're still not keen on that one, you can actually put a tricot, and it can show you with the vitreous coming into the anterior chamber. Okay?
Some people advise that you do posterior capsule rexus and you just make the cross. What is your opinion, sir?
No.
In the vitreous.
See, it's like a sleeping lion. If you wake it up, you better kill it. Okay, so there's no point in cutting the vitreous and leaving it hydrated. No way. No, please don't do that. So please attempt these patients only when your phaco or aspiration machines have a good cutter. And for all my cases in the morning, first thing we do is we check the cutter. We get a new cutter every day. So please spend some time on that, because if you don't do cutting properly vitreous in these ones, your lenses will not be in place. If vitreous coming out, it getting off the center, CME at the back, ovalization of the pupil, there are going to be so many problems. So if you can, please, I think everybody has to learn vitrectomy for the pediatric, period. I'm not going to take any no for that. Okay, so how do you decide? I mean, what happens when the kid is born? All the old good books used to say when the kid is born, they all have ropes. Remember? We all read about it. But I haven't seen any kid wearing glasses. +6, +7, they say, kid has very hyperope. 6 months, 1 year, nobody's wearing glasses. So there was a study by Gordon et al., I think, which all of you must read if you haven't read. It talks about the emmetropization. It talks about when the kid is born, the axis length is short, the cornea is very steep, so it's compensated. So the refractive error, according to them, they did a study in which they took the kids in the nursery, they took the permission from the parents, they put in a drop of cyclopentolate, did the retinoscopy and keratometry in these patients, axis length, and they collated the result, and they found out that +0.5 to -1 is the refractive error you get. Nobody is +5, nobody is +6. Please throw those books out of the window. Now, if in these patients you've taken the lens out of the picture, so you got a cornea, you got a lens. If you've taken the lens out at the age, say 6 months, this equation not going to be followed, right? Otherwise, the cornea is getting flatter and the axis length is increasing. So it's compensating each other. Okay, so a little bit anatomy. It's not a small adult. It's an absolutely different eye. So this eye is going to grow. Axis length in the beginning is about 17. It goes to 24. And keratometry, which is as steep as 52. And especially if you have a unilateral cataract and one eye is smaller, it's a microphthalmic, that means the eye has stopped growing earlier. And you will find in Monga, in most of these unilateral small eyes, keratometry is steep. That tells you that intrauterine life, it's all steep, it's flattening down, but since there's an insert which has stopped it to grow, the eyes are smaller. The size small itself is telling you that the axis length is less and the cornea is still steep. Okay? So these are the two things which they talk about. Okay. So why do we talk about this? I get a child at 1 year, whatever the power comes, I'll put in glass. He doesn't have to wear glasses, but the problem is he's going to grow out of that, and he's going to myopia, which could be a -4, -5, -10, -18. So we've seen patient going to -12, -18 even after the IOLs. So that thing you can't control, but that happens in a very few patients, which are the outliers. So that's why we always take the myopic shift into consideration and make this patient hyperope depending on what you want, with what age. The best rule is Inadi's rule of 7. That means refractive error and the age of the patient. If the age is 6 years, +1. So you need a 1 diopter error. If the patient is 1 year old, you need 6 diopters of glasses in his front of his eyes. And that's a very gross one, but I think in majority of the patient, it works wonderfully well. Okay. So it's the still target you can shoot with the eyes shut also, right? With practice. And we are talking about the moving target because the eye is growing. It's a dynamic eye, it's still growing. So what is going to happen? And let's see about that. Now this is a paper I talked about. So what he talked about was that the normal refractive error at the birth is +4.4 to -0.5. And this was, they've done a huge number of patients. And they realized that if you, okay, all of you know your A constant of your lenses. Even our eyes have a constant. My lens, which is crystal lens, have a constant. And according to Gordon's study, it's 116.4, and which he came out with taking up all the data and putting together and back calculating to calculate the A constant. So we have A constants also. It's not that it's in the lab only, in eyes also have A constant. So this is a study. He's talking to keratometry, triphasic, and the axis length changing accordingly. Now see, this is what he did. He took these kids and 30 to 35 weeks group here, then increasing age, and then he realized that this is what he's getting in all these. Axis length was varying from 15 ±9 keratometry here, and with the SRK lens formula, he could calculate the power and refractive error of these eyes. And I think this is one of the very good studies which every pediatric ophthalmologist has to know, and it's a wonderful study. So what happens now? Refractive changes in the childhood. So aphakic refraction declines from +21 to +14, 11.4 roughly, according to the Scott McCartney. And pseudophakic eyes have a larger myopic shift. That was according to this study. Some people have come out with a calculation on the base of formulas. So wherever the age is, you put a pin. It doesn't work for all patients. Very small cohort of the patient in which the keratometry and excellent are within the limit, you can follow this one. Otherwise, they're more of outliers. So this is what is normal, but most of the outliers are there, so it doesn't work very well. So people have tried all kind of things. So what actually is happening is, in the first 6 months, there's a growth of 0.6 millimeter every month. So 6 into 0.6 becomes 3.6 millimeter. So that means from birth till 6 months, you have got a 3.6 millimeter of the eye which has grown, and which we have seen in our own hands that it happens in all patients. So if you're doing patient of surgery less than 6 months, you have to be very careful. You cannot leave them emmetropic, otherwise you're going to lose everything. So this is where you have to have them higher hyperopic. So I'll come to that later. After 6 months to 18 months, the growth is about a 0.19, about 0.2 millimeter every month, which is not very low, but that's still manageable, right? That much range you can do. But after 2 years, it goes down, and this is a Wilson et al. Study, which I'm quoting. And the other factor which decides the excellence is the age of intervention. IOL versus aphakic, type of lens, rigid versus foldable. There was a study in which they put rigid lens into the sulcus, and they realized that it was actually irritating the ciliary body and causing the excellent to go. So you got to be very careful, and nobody's using a rigid lenses now, so all are foldable. So unilateral versus bilateral. We always think the unilateral eyes are smaller eyes with a small excellent, but there were studies in which they found that these eyes, even after surgery, if they don't use amblyopia treatment, they'll outgrow the other eye also. So they shoot up and go myope. Rehabilitation, if they do properly, if they do the patching well, it works well. IOP, if there's a spike of pressure, those eyes are going to actually go high. We did a study in primary angle closure glaucomas, which Dr. Vinay sent me, and we realized that we have to undercorrect it much, much more than the normal age matched group. So if you're undercorrecting by say 10%, here we're doing about 20 to 30%. It was so high, and it was variable again, because the pressure spikes, the cornea goes so thin, it actually shoots up. And the genetics. Now that's the factor which, if you're sitting in your clinic, like you're sitting in Mayo, your patient growth is different than what we're seeing, say Monga is seeing at center of a site, or maybe Nayan is seeing in Rajasthan. So you have to follow those patients with the same group of ethnicity, and you realize that everything is different. We are all the same, but there are lots of things which are actually in your DNA. You can't change your DNAs, can you? So age of intervention, he said, is what is, she talked about, it's good. I think we agree with that one. Now, effect of the aphakia or pseudophakia or excellent growth, there are lots of paper on that, and actually some papers say that there's no difference, right? And the other one says that excellent retards, and some say it grows faster than what you expect. So these are all studies which you can see. Now that's a chart which talks about, the Lambert study says there's a retardation, whereas the other one says that no difference, and increases. Now all the newer studies which are coming, because I think they're able to measure the excellent biometry is much better. All the newer studies, 2009, 2004 says that there's an increase in these eyes, and you got to be a little careful about that. Okay. So I think Wilson Group sent in a questionnaire to the adult cataracts and the pediatric cataract surgeons to check out what is their take on the IOL power calculation. So what they found out was this one. At the 6 months of age, so first is the ACRS group, the other one is the APOS group. So he wanted to check out what is a pediatric surgeon who's doing it, and what is the adult surgeon's perspective of a pediatric cataract. So what you realize is that the pediatric ones are doing more undercorrection, more hyperopia as compared to the adults, because they're used to the adults. So when they go undercorrection more than say 5%, they start feeling jittery and they don't know what they're doing. But these eyes are dynamic, they're growing, they're going to change, they're going to come back into the zone where you want them to be sooner or later. So now coming to the lens, I think PMMA nobody is using now, we can actually stop it. Unilateral eyes, I think that's the biggest bed bug, and you have to tell the parents that we are trying our best to give them, but it's your input which is more important. Glasses, frequent change of glasses, occlusion treatment, and frequent follow-ups. And if there's an ESO deviation, then you have to do the surgeries also in these patients. Okay. So let's quote about this. When we started these pediatric cataracts about 30 years back, I think these were the people who were doing more work, Dahans and Prost. Then we started copying this one and following this one, and we realized that we were burning our fingers, because most of the hyperopias were actually not regressing. They were doing very high amounts. For example, less than 2 years, they're doing 20%, and 2 to 8 years were 10%, which is pretty high in these patients. And And that's the same thing which Prost has come across. So what we do is we close to what NID's group says, which is good. So what we did in the RP center, we did a thesis which finished about 3 years back, and we're still following the patient. We picked up these cohort in which we had less than 6 months age, 6 months to 1 year, 1 year to 2 years, 2 years to 5 years, and more than 5 years. So in each group we had about a fair number of patients in these one. And we did the excellent keratometry, operated this patient, and then followed all these patients for the last 2 to 3 years. And this was the IOL power which we got in most of the patients, less than 6 months, actually had 25 plus minus 2.5 with a 20% undercorrection. And whereas the bigger one had 2% undercorrection, right? So that's a difference. That much is the shift. And when we did the refraction post-op, so you see we from 0.6 plus to 2.4 to 1.1 to 0.3. So even if you have an error of plus minus 2 diopter in these kids, you should be very happy and pat your back, because even achieving that one is almost impossible, right? So what we do in the center, RP center, is if it's more than 5 years, you can go first hyperope, otherwise you can ignore that also and just go for the imetropic. These eyes not going to grow too much, and if they wear the glasses, the growth is not going to be too much. So you just don't do it, do a imetropic power, whatever you get, just give it. At 5 years, you do 2%, and at 2 years, you give 5%. Simple. Between 1 to 2 years, 10% is absolutely fine. And when I'm talking about this, we actually measure both the eyes. In case we think one eye is not behaving on the excellent well, then if you're doing the smaller eye first, we'll consider that excellent also to be compensated in this eye. 6 months to 1 year is very good. Till 15%, there's no problem at all. We've been doing it for last at least more than 15, 20 years now. We haven't burned our fingers much. The problem is when you have 3 months to 6 months and less than 3 months. If the less than 3 months, and if you're not comfortable, please, you can leave the patient bilateral aphakics. It's a fantastic surgery, bilateral aphakic with glasses. Plus, the only thing you should add on is when you do the surgeries, please, for God's sake, leave some rim in the periphery. Don't eat up the thing like the VR guys do. Whenever we get the patient which are lensectomy done by the VR guys, somewhat hurts the ego to leave any capsule of things in the periphery. They eat up everything. So you have to go to the iris to do some surgery. Otherwise, if you have your rim around, even if you have a 4.5 millimeter rim in the periphery, that's perfect for a 3-piece lens in the sulcus, which I think he told you about the surgery. So now we got 3 to 6 months also under our control. We are managing these patients pretty well. But less than 3 months, we're still doing it because in our scenario, the patient are not going to use contact lenses. Even the aphakic glasses, they'll buy once in a village. If it breaks, they might get second time. If it breaks again, they can't afford, they can't go anywhere. So they don't have money to eat. So what do you do? So that's why we are a little aggressive on the IOL. It's just basically we want them to actually see. So finally, we talk about the ELPs, effective lens position for the adult to make your power calculation accurate. I think it doesn't hold water here because you don't know which lens you're putting where. You might be putting lens with the capture, it might change the power. So using all the glasses, contact lenses, if the patient can afford, should do it. Post-operative refraction, excellent data, I think is a must for everybody who's doing the surgery. If you can follow a patient for 4-5 years, you know where you're heading and what you're doing. If you've done 2 eyes in which one you did a vitrectomy properly, another eye didn't do a good vitrectomy, the eye is excellent. In 5 years, it's going to be different. Take it from me. Because whenever we burned the fingers, we went back and saw the data. Which are the eyes which are same surgery done? What was the problem? Vitrectomy didn't work. So please look into the data. If there's some problem there only. If the same in gap of 3 days you're doing the same procedure, your results should be the same. Okay. I think ideal size is to put in the bag. If not, the sulcus works well. I think. All right. So I'll just conclude now. So this is what I'm trying to show. See, this guy is trying to shoot emetropia, but he misses out, right? Now he goes and checks up and checks our, he attends our symposia also. Now he's become wiser. He knows the eye is growing. I don't have to shoot at it. I have to shoot in front of it so it comes and hits a target. So now I think this guy has become wiser and he shoots and bullseye. So bullseye doesn't mean a 0 refractive error. A plus minus 2, you're good. If it's minus 2, the chances are that minus 2 might increase further. If it's plus 2, you're still happy about it. And you should be content with that. Just keep wearing glasses and compensate for refractive errors. And thank you very much for your kind listening. So we have a last speaker and then we have your one. So next is, we got OCT. We're using OCT for the last 4-5 years. We got 10 microscope with the AIOS20. we damage so much to the national money. And we use UBMs. So Dr. Amar is going to tell about what are the roles of UBMs and IOCTs. Because wherever I go, they all talk about IOCTs on the table. I mean, we're doing it. I'm not talking about that for this course because I don't want you to waste money on that. If you can afford it, well. If you can't, you can do without. So Amar, let's listen to you.
Yes, sir. Good afternoon, sir. Good afternoon, everyone. So I'll be covering the part of UBM and IOCT in pediatric cataract. So to introduce, we all know that UBM is a contact procedure and it is a pre-operative imaging. It is not an intraoperative imaging. So it has low resolution and it wants to give much larger field of the anti-segment, and it provides the macro detail. Macro means it's going to give more about the corneal, antechamber and total lens dimensions. In contrast, if you compare with the IOCT, which is going to be a non-contact procedure, there is no touch of the eye, so it is going to be intraoperative. While you are operating or before operating, you want to see how the lens, which includes the anticapsule, intralenticular and the posterior capsular changes looks like. And it's going to be high resolution because it is going to cover a very small area. That's why it is going to have better resolution, and it provides the micro details. So to begin with UBM, it's a 35 megahertz which we are going to use routinely, and as most of the speakers have said that it's going to give parameters related to lens thickness, which is very important, and back diameter, because once you want to put the IOL, we need to have a back diameter dimension, then only you will decide how the IOL is going to behave in the back, right? So if IOL support, sorry, back support is not there, then you want, or you are curious about the sulcus diameter, that will help in understanding how the multipiece is going to behave, and of course the antechamber depth for research purposes. So this is how we do UBM, and you can see that patient is lying under general anesthesia. So you are going to use this cup. So these are plastic and rubber cups, so which are available for different sizes. So kit could be small and kit could be large, or even it could be adult. So depending on that one, you are going to have 3 to 4 cup sizes of different dimensions. So you are going to use whichever fits for the eye, and you are going to retract both the lids, and you are going to keep around the limbus. Make sure that you are not going to rub or touch the cornea. You are not going to cause any corneal haze or epithelial defect. So once you put that one, you are going to slightly indent on the sclera so that it should not be leaky. After that, you are going to inject the saline, right? So you are going to fill it. You can fill more than 50% of the total cup height. So after that, you are going to take the probe and you are going to insert it into the liquid. After that, you are going to press it on the monitor just to say start the scan. So once you do that one, you can see that here you are able to see the lens details. So the more you move into the water, the scan will move up. So that's how it is going to say that don't touch the probe, and if you more move upwards, the scan moves down. So it should be in between so that it exactly fits, so that it gives the details from the epithelial suffix till the anterior vitreous, because we want to see the PCD changes also in some cases. So here in traumatic case, you can see that you can see the iris configuration. On this side there is a gap between the posterior surface of the iris and the lens capsule. It means that probably volume has contracted, the lens volume. Here you can see that there is a PC breach. Because of that, when the iris is stuck to the anticapsule and the lens matter is herniating into the sulcus, right? So you need to lift up this iris and you need to do the rhexis. Probably you are not going to get any anticapsular support here. So that's how you got to know that there is an anticapsular breach and the lens matter has escaped into the sulcus. Of course, the posterior capsule is intact, but this is the vital information which you are going to get on UBM. And one more thing is, like when we are doing the scan, UBM scan, you need to put the cup here. So there will be a probe which is vibrating, right? So if this is a corneal diameter, you need to take it from the temporal to the nasal, so that you are going to get all the changes from nasal to temporal. Similarly, you need to rotate the probe and you need to come from the inferior to the superior side. So that's why you are going to cover the 360 degree of the eye while scanning. So I'm going to explain the practical application of UBM using some of the examples. So this is set 1. You can see that there is a wide cataract. You don't know what is the capsular status, how the posterior segment is. So in these cases, rather than just like jumping into surgery, if you do UBM, here you can see that how to read a UBM. So this is a good UBM in both the cases, and this is right eye and this is left eye, the same patient. Here, as previously I said, you can see that there's a gap between the iris and the lens capsule. It means that lens volume has contracted. Either it could be a small lens, or it could be absorbed cataract in traumatic cases, or it could be congenital cataract where there's a PC deficiency. That's what you are able to see here. The anterior capsule is flat, otherwise it will be convex, but here it is flat because the volume has been lost through posterior capsular dehiscence. So you can see that the anterior capsular, cortical matter in the anterior vitreous, and there's a breach in the posterior capsule. Similarly, in the other eye, you can see there's a much more absorbed cataract, and again there is a PC breach, and that's how there's a cortical matter in the anterior vitreous. So of course, by looking at this one, you are going to change your IOP parameters, whether you want to introduce the IA Pro first or the cutter first. Everything changes based on the UBM finding. So this is second case where through different PCOs we want to see how the PC is exactly. So here you can see that this is a very flimsy PC which comes through IA probe only. So in other cases, on the right side you can see that this is a fibrotic plaque sort of thing, anterior capsular phimosis sort of thing. So you want to see that whether this is fluffy. If it is fluffy, it can come through IA probe, bimanual aspiration, right? So otherwise here you probably need to give a nick through MVR, or you need to cut using intravitreal scissors, then do a rexus sort of thing using intravitreal forceps. So that's how it will help in differentiating what sort of opacity you have, and it also helps in assessing if you are putting the lens in the bag or the sulcus, is it tilting, is it like equally aligned on both the sides. That's how UBM is going to tell about the posterior capsular opacification and also the lens status. So this is one more case with anterior subluxation of the lens because of spirophakia. You can see that the lens is touching the endothelium. These are for educational purpose. Of course, we will see on the slit lamp or during microscope, but that's how you are going to tell the findings to the naive surgeons or the young people who are like studying the cases, right? So this is one more case where you can see again there's a white cataract, but there's no PC deficiency, but the bag is so thick. So because of this one, you are going to have a very thin posterior capsule. So you'll be having a difficulty in doing PCC. That's how you are going to understand through the UBM. And here you can see that this is a zonular with riders. Again, the lens volume is normal, the anterior capsule and posterior capsule looks clear, and you are not going to have any problem here. So the next comes the IOCT. IOCT is an intraoperative thing. So as I previously said, the UBM gives the macro details and it gives the micro details. So it's going to have a circle here. It has a vertical scan and the horizontal scan that can be moved on the microscope itself, and you can just move that one to the area of interest. One negative factor about IOCT is it's not going to give any details below the iris because it's a light dependent phenomena. It's going to image only through the clear axis. So if you do UBM, you'll be able to see some sort of plaque, but here if you do IOCT, you can define the plaque. Okay, there's a plaque here, and to what extent it is extending? Oh, it is extending from here to here. Can I cover the plaque within the rexus, or it's going to hamper my rexus, right? So it is in the center, you can do the rexus. And if you want to do rexus here, see, you can see it is not a normal capsule here. On the right side, you can see this capsule is normal. You can do a good rexus here, but probably you need to put more force here, or you need to cut it here. So that's how you are going to decide the micro details on AIOS20, right? And this is the second details. That was anterior capsular changes on IOS20. These are micro details, and this is the intralenticular and the posterior capsular changes. So here the surgeon is doing the hydrodissection. Of course, Professor Coker is the surgeon here. And once you do the hydrodissection, how the lens material is behaving. In some cases, some membranous cataract, the material won't dissect it out. So in those cases, probably you need to use phacoaspiration. So those are the indications which you can understand. Okay, here you are injecting the fluid into the lens matter, and you are able to see that the lens matter is sort of loose. So that's how you can take it out using bimanual aspiration. So on the right side, you can see that there's again PC deficiency. So you can see that both the leaflets of the capsule are falling into the anterior vitreous, and again, AIOS20 helps in understanding, okay, the lens volume is very small. Once you do the rexus, hardly there will be any lens matter to aspirate. That is the first thing. And second thing is you should not be putting too much IOP so that can go into the anterior vitreous. Of course, you will be taking it out, but you'll make sure that it won't dislocate further. Of course, the vitreous is going to be firm in pediatric cases, but here it can go into the anterior vitreous, and of course in some cases posterior vitreous also. But by using this image, you can be more sure, you can prepare your minds, and you can change your parameters. This is one more interesting case scenarios. So we have two different cases where anterior capsule rexus has been done, and we have taken out the lens matter. Now there is a posterior capsular plaque. How AIOS20 can be useful in these case scenarios, right? On the left side, in the dark black images, you can see that there is a posterior capsular plaque is there, of course, right? But here you can see that the posterior capsular plaque is quite thick. That is first thing. Second thing is whatever the duplicated layer is there, it is in the anterior vitreous. It is not in the bag. And probably if you want to take it out, probably it's not going to come through just by manual aspiration, or you won't be able to do the puncture using the needle. That is the first thing. And you won't be able to do a PCCC using any intravitreal forceps because it is quite thick. It can run away. That is the thing. So probably you need to put a stab incision here, then use the intravitreal scissors and fashion it out. So if you do that one, obviously you won't be able to put the lens in the bag. Probably you need to put in the sulcus. So this is how AIOS is going to tell you that this capsule is very thick. It is very fibrotic. Probably it's not going to come through your simple needle, tomy and intravitreal forceps, right? So on the right side, you can see that the fibrotic plaque lies in front of the capsule. You can see here on the lower image, I can see, you can see that arrowhead, right? So it is actually elevating on the anti-surface of the capsule. So that's why Kokasa, what he does is like he takes the Sinsky and he just peels that one. He peels that one and he just rotates it, right? So you can just clean it. It's like you are like wiping the floor, right? So you can just pull it up and you can do the rexus sort of thing. So that's how you can avoid any capsular damage. So there, once you take out the plaque, which you got to know through AIOS, it is not behind the capsule, it is anterior to capsule. Once you take it out, then you can do a round PCC, then you can put the IOL in the bag. So that's how AIOS helps in understanding how the plaque behaves, whether the plaque, the duplicated layer is behind the posterior capsule or anterior to posterior capsule, which otherwise you can't decipher here, right? So this is one more interesting case where the patient underwent surgery and there is a opacity here, right? Under the microscope, you are able to see that, okay, how I can take it out. So, but AIOS comes to rescue. It shows that, okay, this is a well-defined posterior capsule and it is in the Berger space, right? So Berger space has been dissected and there is a reaction here, and in that particular space, there are some reactionary materials are there, right? So surgeon does a small opening here and he's trying to inject it, and you can see that after putting some viscoelastic, the space is expanding, right? So he's going to do a rexus here and he's going to take it out, right? So otherwise, if you are doing just based on microscopic view, or if surgeon is naive, probably he feels that there is something on the back. So if you do OCT, it shows that just it is beneath the posterior capsule. You can take it out by doing a good PCC. So to conclude, UBM is an essential tool. It is an essential tool in pediatric cataracts. You cannot do pediatric cataract surgery without UBM. Of course you can do, but most of the times, in more than 90% of the cases, it gives some sort of details. What is the sulcus, how the sulcus is, how is the anticapsule, how is the lens. And that's why it's an essential tool in imaging pediatric cataract, where it reveals specific finding related to antechamber depth, lens and the sulcus. In contrast, AIOS is a supportive tool. It's going to support your findings. It's going to be supportive during your surgeries. So which is going to give intralenticular details, anticapsular detail, postcapsular details and the anterior details in a microform. It is going to be in a macroform or a larger view. Thank you.
Thank you, Umar. I think we got a guest speaker now, and after that we open to the questions. She's going to be talking about dry eye in pediatric. I think it's on that one. That mic. So you can switch over. So in the meantime, if you have any questions, I think. These are all on the OT. These are all kids under anesthesia. No. None of this is OPD. This AIOS OCT is on the microscope. These microscopes. You mean on the table. These kids were not allowed. No. All these are on the table, please. Not in the OPD. For the adults in the OPD, you can make them lie down, and they have to lie down and do it. I mean, you can't do it with vertical. That's how it works. Please.
I was just wondering about, the glaucoma, post-op glaucoma, our experience,
Yeah, okay.
both aphakic and pseudophakic.
Right. So I think whenever we have these smaller eyes, he mentioned that we always do,
Yes.
when we do a UA, we always measure the thickness of the cornea and we use a IOP measure. And if you do the surgeries clean, whatever the Western data was to say that they used to get lots of glaucoma, we're not getting those many. Maybe the genetic, again the ethnicity, we don't have that much. But the patient who have glaucoma and cataract, those are the one which are very tricky. And that in those ones, the excellence is definitely going to shoot up more than what it is. Otherwise, no. We're not getting. And especially if you've done a good core vitrectomy, and that's, I think you should all do in all the patients. Less than 6-year core vitrectomy is, I think, is mandatory in these ones. What happens is you're putting a big adult lens in the eyes, and we did a study, we just published in AIOS, we didn't put the data. We did a UBM in about a 750 patients in which we did a UBM measuring the sulcus to sulcus, the bag diameter, white to white. We realized in Indian setup, the bag diameter is never more than 9. I mean, 7.5 to 8.5. And these lenses are 12.5 opening in. Because you done a good vitrectomy and the posterior capsule falls back, it creates a volume inside for the lens to come. We don't have the pediatric cataracts available anywhere in the world because I don't know why these people don't make it, but they don't because they say the population is. But I think we should insist on smaller lens. But if you've done a good vitrectomy with a PCC, ACC, your adult lenses actually, especially these single pieces, they go very well into the bag. That's what you should do. And any other thing you wanted to ask? Sure, you can open because I think she's taking that. Please, you can ask me in the hospital. Yeah, please. Yeah, come. Ask. Use the mic.
So there is one undercorrection which is according to age.
Yes, ma'am.
So however, if you place an IOL when the axial length is around 17, what other undercorrection do you use, sir?
Age is what?
Not specific.
Okay, so I don't go by the, I go by the anatomy of the eye. If my eye is healthy, 17 millimeter and above, whatever the age, I'll put an implant. I just told you that if AKICs don't do very well, they lose the glasses, they don't get better glasses, they get scratches. And contact lenses in India, we don't have a good setup. Let's be very frank about that. We don't have a good contact lens setup for the pediatric age group. For adults, even on the roadside, anybody can put in a lens with a common T. I mean, anybody can put it. But for the pediatric, where it needs a skill, they need anesthesia, they need to put a refraction and change it. They don't do it. But eye sees the anatomy of the eye. If the eye is healthy, go for it. Okay, sorry, it's all
That's
yours.
okay, thank you. As a pediatric surgeon, I enjoyed a lot your session. Congratulations, it was really nice. My name is Sihab Lazarek. I'm from Algeria, and I'm here on behalf of the French Society of Ophthalmology. I'm a member of the board, and it's one of the oldest societies in the world. It's 140 years old. My talk today is on the pediatric dry eye. And I will start my talk by one of my cases, one of my patients. She's a 6 years old girl, and she was referred to me just for a certificate. It was a hopeless case. She saw many colleagues, and she was treated for allergy, for herpes disease, and this was her cornea's bilateral neovascles in the cornea the first day. And she was referred as the last hope, and also for a certificate to go in a special school because she was in the age of school. Then, pediatric dry eye is maybe frequent, but it's not very known. It's underdiagnosed and estimated because children are not complaining. The tendency of children to report fewer symptoms compared to adults for similar degree of ocular damage may also lead to this under-reporting of this ocular surface problem. And this, in this case, in pediatric dry eye, we can have many comorbidities, and it can lead to many causes. And it can occur with the number of congenital, autoimmune, endocrine, or inflammatory disorders. And in this presentation, we'll discuss some epidemiology and all of these etiologies. Concerning the epidemiology, all of us, we know that dry eye is a very frequent disease, and in adults, it's reported to be the prevalence from 5 to 50%. And there is really a paucity in publications in the pediatric cases. Some studies, and 4 of them, reported dry eye in children to be 10 to 44%. And there is a little or no information in all the publication regarding the impact of the signs and symptoms in the children population. The signs and symptoms are same in adults, but the children are less complaining. They have the redness, the itching, the hypersensitivity to light, exactly the same symptoms, but the complaining is really less. And to do the clinical examination, when you can put the child into the slit lamp, it's easy, but if not, it's less more complicated. and we can as well perform all the chamber test, breakup time, and all the automatized machines and examinations. What are the causes in this population? MGD is the first cause, environmental, allergy, congenital, or GVHD. The GVHD, or ocular rosacea, is defined as a posterior blepharitis, as it's very, very common, at least in my country and in the Mediterranean area. It's a very common disease in children. We have many rosacea and many MGD in pediatric population, and the main manifestation in children, it will be chalazion. Then, when we have a recurrent chalazion, we need to see what's happening into the meibomian glands, and in most of cases, if we are not treating at this stage, we can see all the complications after. Then the recurrent chalazion is the most frequent symptoms. Then we have the corneal involvement, and we can have many of them. We can have follicular keratoconjunctivitis, keratitis, infiltrate, neovascles, and even perforations or corneal ulcers. And as you see, all these pictures are belonging to pediatric people. Then back to my patient. Then it was her picture at day 0. And as I told you, it was a hopeless case, bilateral blindness. And I started to examine her, and just I asked her father one question: did she expected any chalazion? And he told me yes. Many years ago, when she was 2 years ago, she had a recurrent chalazion. It was only the key point. And then I told him, let us just try a treatment, and if it doesn't work, after 3 or 4 months, I can give you the certificate to go to the blind school. And then, fortunately, as you see, after only 2 weeks of treatment, she was like this. After 1 month, she was like this. After 2 months, this is her picture. And the surprise is now, this is her picture. Then, thank you. And really, it was one of my very altruistic cases, not only clinically, because she was blind and the parents were really hopeless. And only if you do only a questionnaire, if you just ask one question, we save all her life, because she was supposed to be blind, and she was treated for herpes zoster, for a severe allergy. She had many treatments, and she saw many doctors, and they didn't ask only one question. And don't expect to see the rosacea before the clinical, before the eyes. She developed, this is the girl, she developed the rosacea 3 years later. Then don't wait for the skin manifestation before the ocular manifestation. And in children especially, they can develop the problem, the ophthalmology problem, before the skin problems. The second etiology of dry eye in pediatric population can be environmental and lifestyle. And as you know, all our childs now are on the screens, and this is one of the most reasons of dry eye in children that I am seeing in my office, and they are all exposed to environmental and ocular challenges. Then we have an increase of reports of dry eye in pediatric population due to the use of the screens, and they are all on their smartphones or on their tablets. And I found many papers on that. And we have also inadequate blinking. They don't know how to blink. They have, when they have problem in their refraction, it can lead to dry eye. All the myopia treatment that we are giving to our patient are preserved, and then they are developing as well dry eye. And in my country and in Africa, maybe in India also, we have a vitamin A deficiency, and it can lead to dry eye also in this pediatric population. The ocular allergy and the dry eye are for sure very, there is a big relationship. I'm seeing thousands, I can say thousands of VKC, because in Algeria it's a warm climate, and I think that in India it's the same. And they all developing because of the chronic inflammation, because of the chronic ocular surface disease. They are developing meibomian gland dysfunction, dry eye, and this relationship is now not to demonstrate it's a fact. Then we need to treat both the ocular allergy and the ocular dry eye and the dry eye. GVHD, the bone marrow graft is a saving procedure. There is no doubt. And now our colleagues hematologists are doing more and more because they are extending the indications. Then for the beta thalassemia, for many diseases, they are doing bone marrow graft. And I'm seeing in my clinic many pediatric GVHD. They are really very, very miserable because the disease is very severe, and they are developing the ophthalmic symptoms are really very, very important. Then in these patients, we need to take care of them. Once they do the bone marrow, we take care of their eyes because they are developing severe dry eye and severe corneal involvement. We have also many congenital dry eye disease, congenital alachremia, aniridia, congenital anesthesia, and as you see, this is a 3 years old boy with a congenital plasminogen deficiency, which is very common as well in Algeria. I don't know here, but it's common, and it's one of the causes of dry eye in children. Then how can we manage this dry eye in children? The same as in adults, but we need to explain the MGD treatment and the lid hygiene, because in pediatric population it's not so easy. Then we need to explain to the parents how to do the eyelid hygiene, the massage and the warming. We can perform IPL, I'm performing whatever the age, and we can also perform a manual or automatic hygiene with the blepharo exfoliation. It's very effective in the treatment of chalazion in the pediatric population. For the antibiotics, this is what I gave to my patient. I gave a treatment of azithromycin. It was a local azithromycin twice a day for 5 days, and I repeat the treatment 3 months. And for the first course, I'm giving steroids for the same 6 times per day for the same period. Then I repeat the treatment 3 months, and you saw the results. The anti-inflammatory drugs, we give steroids and also cyclosporin, tacrolimus in the severe cases. The prevention of dry eye is the entourage, is to explain to them to avoid the screens, to help them to teach them how to blink, and to wear the correction. Just to conclude one word, the dry eye in children is not that rare. This is now it's a common condition, and we need to give them more attention than adults, because they are not complaining, and when we are seeing them at in the stage of complication. Just please join us this year. We have a new society. It will be our 3rd Congress, the Dry Eye and Ocular Surface Society, and our next meeting will be in Bangalore, here in India. Please join us, and you are very welcome. Thank you for your attention.
Okay,
it was topical azithromycin twice a day for 5 days, and I give 3 months, 5 days per month. And the first month I gave steroids 6 times per day for 6 days, and eyelid hygiene and.
Thank you for the fascinating lecture. But the thing is, you said about the mobile laptop syndrome. Dry eye is not that common in this mobile laptop syndrome, as the children who are addicted to the smartphones, they complain of eye ache, headache, irritability, change in behavior. They might get abdominal pain, migraine. Then there are reports of delayed milestones, epileptic attacks. Later on, they will develop ophthalmoplegia, diplopia, spit. So the thing is that the dry eye is not that common entity in mobile as these are the things. The other thing which you talk about, this rosacea, one of the slides which you showed, it looked like to be a vernal plaque. Lunar plaque is one of the complications of bubble carotid conjunctivitis. That's what's called spring catarrh. So that is. So the thing is, one of the features of the spring catarrh or bubble carotid conjunctivitis is a corner dystrophy. Corner dystrophy in
Thank
bubble
you.
carotid conjunctivitis is not because of the allergy, because of independent entity.
Oh, okay.
It's independent, where they will get
Oh, okay.
expressive
Thank you.
conjunctivitis.
I think, thank you, please, we are already
This is
running.
important. Give
Yeah.
me some time.
No, so you can discuss.